Okay, I would like to thank the organizers of the meeting for the invitation to speak with you all today. And I was asked to present an argument for a more intensive or transplant-based strategy for a younger patient with newly diagnosed mantle cell lymphoma. So I will, in an attempt to do this, first cover some retrospective data. There'll be a little overlap with what Dr. Martin's already presented, but we'll start with retrospective data. We'll go then to some prospective studies looking at transplant. And unless I say otherwise, when I talk about transplant, I'm referring to autologous stem cell transplantation. I'll then try to compare, at the risk of comparing across studies, what kind of outcomes we can expect with transplant versus non-transplant approaches. I'll then make an argument that PFS does matter in mantle cell lymphoma and that preventing relapse is an important endpoint for this disease. And then I'll finish, you stole a little bit of my thunder, but I'm going to finish by talking about a risk-adapted approach that may allow us to be a little more intelligent about how we select patients who might stand to benefit from auto transplant. So in terms of the retrospective data then, there's several studies out there. I chose a couple that I thought were informative. This is a study from Germany which looked at data from two different eras. So the yellow curve is from the 70s and 80s, where the median survival was 2.7 years, and the blue curve was a more recent cohort, about 20 years later, in which the median overall survival was about 2.1 years longer. They tried to correct by matching for differences, but still, of course, there's many different factors, and the big question is, why did the overall survival improve? There was a significant increase in the use of autologous transplant in the more recent cohort, but there was also an increased use of anthracycline, rituximab, and of course, better supportive care as time goes on. Looking at the Nordic lymphoma database, or Swedish-Danish registry again, but breaking I think you showed some data from this, but this figure here shows if you divide the two cohorts into those who got an auto transplant versus those who didn't. This is about a 1,400 patient study, retrospective. And the two factors that were most associated with improved survival on multivariate analysis were the receipt of rituximab as well as autologous transplant. Now, of course, there's always going to be selection bias in terms of who gets selected to have an auto transplant, but for your patient who is a transplant candidate, I think this type of data says these are the kinds of results you can expect in the real world with a patient who is able to go through the rigors of intensive therapy and auto transplant, where you can see that going out about 8 to 10 years, most of those patients were still alive. Using the CIBMTR transplant registry, we published this data a couple years ago. So the four curves shown here are looking at whether people got an auto transplant versus an allo transplant as their first transplant for mantle cell lymphoma, and then whether they got it early in the disease course or late. And I don't have time to discuss how we defined early, but just think about early transplant as part of their first-line therapy. So really, the yellow curve there shows that, again, in sort of the real world, these are people undergoing transplant all across North America and some other countries, that you can expect, and this is before the introduction of novel agents for the most part, the majority of your patients still progression-free 3, 4, 5 years later. This is really before the use of maintenance therapy post-transplant and before the incorporation of novel agents, but it gives you a snapshot of kind of real-world outcomes with auto transplant. As far as the timing of transplant, we tried to look at that in this study as well. And so this is so normally when you report on outcomes in a transplant study, you're looking at from the time of transplant forward. And for this kind of sub-analysis in the study, we looked at time from diagnosis forward. And so you have to do something called a left truncated analysis to to pull this off statistically, but the point is if you compare the yellow and the gray curves, that's if you had an auto transplant early versus later in the disease course, there was about a 10 to 15% improvement in survival post-diagnosis. So this isn't comparing transplant to no transplant, but it does say if you think your patient is a candidate for an auto transplant, it may be better to think about that early rather than saving it for later. I was lucky enough to have a kind of an uber HEMONC fellow for the past few years named Narain Epperla, who's going to be taking a faculty position at Ohio State when he finishes. And he did a couple of, quite a few research studies during his fellowship. One was using the SEER registry. And so this is data that's in press at British Journal of Hematology. And so focusing on stage 4 mantle cell patients, looking at 2 different eras, so 2000 to 2006 and 2007 to 13, you can see that the overall survival has improved, and this is about 4,000 some patients, has improved by about 7% at 5 years. And again, the question would be, well, why is that? And there's all those same explanations that I put forth earlier. Could be increased use of transplant, new drugs, better supportive care, all of the above. So we tried to break this down a little bit. So if you look at different age groups, you can see the very old, 75 and older, really no improvement in survival. The very young patients with mantle cell, again, continue to do relatively well. It's these middle groups, 50 to 64 and 65 to 74, where the real increase in survival has been seen. And so, and this is not a research study, this isn't even an abstract at a meeting, but just for the sake of argument, I then overlaid data from the CIBMTR for the same time frame. And so you can see over 75, of course, very little transplant activity. Under 50 is kind of an uncommon scenario for mantle cell. So the numbers, I'm looking at numbers of auto transplants in these 2 time frames, went up a little bit in the under 50s, but in the 50 to 64 and the 65 to 74, that's where you see a 3 to 4-fold increase in auto transplant activity. It doesn't prove that that's why the survival has improved here, but I think it's suggestive that may be part of the explanation. What about prospective data? I won't spend too much time on this since this was already just discussed, but there is one prospective randomized trial that showed basically a PFS benefit and a borderline significant survival benefit. I think many of us would consider this trial to be not real relevant now as far as how we treat patients. We don't use interferon maintenance, we don't use total body irradiation as our auto transplant, and many of these patients did not get rituximab with their induction, and there was really no consistent use of Ara-C either. That's the one kind of prospective randomized trial comparing a transplant versus a non-transplant study or approach which has been presented to date. Nordic MCL2 study you already heard about. The point I wanted to make here is that the median PFS with this approach was 8.5 years. That's for the whole group. If you look at those who actually got a transplant, the median PFS was 11 years. And this is really feasible to give. At our institution, we can give this entire regimen on an outpatient basis, including the auto transplant. So it is a problem if they want to keep working, you're right, and it's a problem if they live 2 or 3 hours away, but those things aside, this is feasible to give to patients up to 65, even a little older than 65. And then the RCHOP, RDHAP study, again, 9.1-year median time to treatment failure. So very good initial duration of first response. And then I just kind of put the recent study that from the Lima group that was presented at ASH. This was induction using RDHAP, followed by an auto transplant, and then the randomization was observation versus maintenance rituximab, with at 4 years already a very significant improvement in PFS and even a 7% improvement in overall survival. So I think approaches like RCHOP, RDHAP, or the Nordic regimen, if you tack on maintenance rituximab, those outcomes may be even better than what was published. So trying to compare these 2 approaches is a challenge. If you look, I just took the 3 intensive approaches that I presented. If you try to kind of summarize those, you see about an 8 to 10 year median PFS and a 10 or more year median overall survival. And just selecting, 6, I think, representative studies using non-intensive induction. These are all studies that had more than 50 patients. What you see is about 2 to 4, maybe a little bit longer in some of the more recent studies, median PFS. So I don't think there's much debate that you can get a longer PFS with the more intensive approach. And the question then is, does PFS really matter in mantle cell? And I would argue that it is. Mantle cell lymphoma is not follicular lymphoma. And I think relapse is worth preventing in these patients. And unlike this picturesque setting here, a relapse of mantle cell is no picnic. So if you look at these several studies here, this is an EBMT study showing what happens after patients relapse following an auto transplant. Median survival of that entire group was 19 months. And then Dr. Martin's study looking at what happens after patients progress or fail ibrutinib. Those patients had a very poor outcome of about six months survival. This same Uber fellow that I referred to, Dr. Perla, did a similar study looking at multiple centers, pooling data, kind of real world study of ibrutinib and mantle cell lymphoma. It was about a year behind Dr. Martin's group, so we published it a little bit later, but the result was similar. The outcomes were dismal. If you fail ibrutinib after either don't respond to it or progress on ibrutinib, the median survival we saw in this study was only 2.5 months. So I think ibrutinib, and we have other novel agents that there's excitement about too. I think these drugs are moving the field forward, but I would caution people not to get a sense of euphoria about these drugs. And patients, it's easy to fall into this. They're on ibrutinib or lenalidomide, and they're responding, and we're doing great here, but this is not solving the problem. This person is probably heading for trouble in the next year or two, and I would argue that's the time frame to start thinking potentially about an allo transplant if they've already had an auto transplant or another intensive induction like hyper-CVAD. Because if you look at what you can expect in relapsed refractory mantle cell, this is again pooling several key studies, the overall PFS historically has been about a year, maybe a little bit better in more recent studies, and the overall survival has traditionally been about 2 years, maybe 3 in more recent studies. So once the patient relapses with mantle cell, the clock is ticking, and so I would argue, especially for younger patients, the goal should be to try to achieve the longest possible first remission for that patient. Because otherwise, you're going to be looking at this data regarding allo transplant once your patient relapses, and the fact is that this remains the one curative option for relapsed mantle cell lymphoma, and we all know there are toxicities and challenges associated with an allo transplant. So do we really want to feel compelled to play this allo transplant card 2 to 4 years into the patient's disease course when you could kick it down the road maybe 8 or 10 years? So it's also, I think, the psychology for the patient is a little bit better, having a longer first remission, knowing that odds are that they won't have to think about this maybe for 6 or 8 or 10 years down the road. This, of course, excludes the ultra-high-risk patients, which I would agree we don't have a great treatment for, even using the intensive options. So this is the patient waiting for the next shoe to drop if they use less intensive therapy. So can we develop risk-adaptive therapies? Mantle cell is not a one-size-fits-all disease. You saw that there are some biomarkers that identify very high-risk patients, and I think we need to start thinking that way for these patients. And one way to try to separate these patients out is minimal residual disease. So this is data from Europe in which they did a landmark analysis at either 1 year or 2 year into their disease. And if the patients achieve a minimal residual disease negative state, as you would expect, their outcomes are much better. And so this observation is being worked into the upcoming National Clinical Trials Network study that Dr. Martin referred to for younger patients, which will take patients who had any induction. They will then undergo an MRD analysis as well as restaging. If they are in a complete response and MRD negative, they're then eligible for this randomization to either auto transplant with 3 years of maintenance rituximab, or deferral of the auto transplant and then just maintenance rituximab alone. Idea being that these are the patients who are potentially going to do quite well no matter what and may derive less benefit from an auto transplant up front. So hopefully you all will watch for this study and consider enrolling patients on that. So to summarize then, for younger mantle cell patients, when combined with induction that includes rituximab and Ara-C, consolidation with auto transplant leads to longer PFS versus non-transplant approaches, can avoid additional therapy in many cases for 8 to 10 years or even longer, has modest late toxicities, avoids the need for continuous therapy. I didn't have time to get into this, but I'm having these discussions with patients more and more when you're starting them on ibrutinib or whatever that second or third line therapy is. So I just stay on this pill forever, and as far as we know, yeah. And I think most importantly, avoids or defers the need to think about an allotransplant in these patients. So with that, I thank everyone for their attention.